I am going to be opening this session, and I'm very pleased to be talking generally about research developments, and this will be research developments across the spectrum. And the theme I'd like to underscore is how important all of our progress is when we work together to do so. And I'd like to especially underscore the value of the family presence at these conferences. The first conference I attended was in 2001, and it was a family science conference held in UCLA and hosted by Liz Neufeld. And it was the family presence and the solidarity between the families that was really the thing that set the tone for the collaboration between the investigators. And it was one of the things that really cemented in my mind the value of staying in this field and pushing forward to develop therapies for all the kids and families out there. So I'll be giving a very brief overview of activity within the society. Some of that's not very germane, but it's important to let you know about. Also, there are 2 science opportunities for families to participate in at the 38th Annual Family Conference. There are grant initiatives I would like to cover, and also the advocacy that the Society has been involved in newborn screening, regulatory issues, and legislative issues around ultra-rare disease. We'll also be talking about some highlights of clinical research that will be highlighted further in this talk. So within the Society, we've not had a standing research committee, and we have set one up. It is part of our strategic plan. It has a chair, Steve Holland, members from the board, and its duties are sort of to act as intermediaries between the scientific advisory board and the broader board, and also to help relay science to the broader community. We meet monthly, and it's been a real improvement. We also have a guidance committee within the scientific advisory board. There are some changes there. Kim Hemsley will cycle off as chair. Julie Isengart, who you will hear from later today, will become the acting chair of the board, and Lachlan Smith, who is a researcher at the University of Pennsylvania, will become associate chair. We're also welcoming 2 new members to our guidance committee because Dr. Leila Simonaro and Allison Bradbury are cycling off, and those 2 new individuals are Adriana Montano and Matthew Pendleton. One of the things that really makes the Society work and makes us able to advance research is we have a broad network of researchers worldwide, and we need to expand that as we develop more capacity and as individuals retire. So as part of that, we wanted to bring in new expertise, including clinical neurology, cardiology, orthopedics, as well as additional newborn screening expertise. We did that by our network of representatives from universities around the world, as well as other countries that may not be represented on the scientific advisory board. To that end, I'm pleased that at the board meeting yesterday, the board of directors approved these new members of the scientific advisory board, and many of these may be names known to you. Liz Bronlin, Guy Baldo, who is a individual that came up through Roberto Giuliani's research group, Maria Fuller herself, excellent researcher, but started in John Hopwood, sort of my generation. Natalia Gomez Ospina, a gene therapy medical geneticist at Stanford. Simon Jones, well known to this community. Deepa Rajan, who is the head or pediatric neurologist at Pittsburgh, and David Whiteman, who's well known to many of us. So I think that this will continue to help drive excellent research at the Society. As many of you know, I will be departing this spring as the CSO. The Society has initiated a search. We have finalized candidates, and Terry is looking to bring a new candidate in. And the Society, I'm glad to say, has committed to at least a couple of months, maybe more, of overlap. And I think we're gonna find a really super replacement for myself. I don't leave you without a sense of tinged with bittersweetness, but I feel certain that the new successor in this position is going to do an excellent job for the Society. I wanted to highlight opportunities for families to engage in research at this conference. One of those is a group called Worldwide Clinical Trials. They have a survey and they're very keen to get family participation so that they can better understand what are the things that help or hinder a family considering going into a clinical trial. So I really strongly encourage you to visit them and to consider taking that survey. Do we have anybody from Worldwide here that can stand up, or are they all out manning their table? They must be at their table. Additionally, if you did not get to the sessions yesterday, ClinGen and Genome Connect are here. This is also an opportunity for individuals to engage in research to help drive a better understanding of alleles associated with the MPSs. And that's headed up by Caitlin. Caitlin, can you stand up? So she would love to visit with you if you would be interested in being involved in this kind of effort. It is very helpful to those of us who are involved in classifying alleles associated with the MPSs. So a huge effort at the Society is trying to make sure that our research meets unmet needs in the society of their patient community and to try and give hope to everybody. From the beginning, two of the diseases that have captured my imagination because of the demands that they share are MPS IIIC and ML2-3. These are non-soluble protein defects, membrane-bound defects. And when I first arrived in 2001, we set a priority of funding research to address these issues. And I'm happy to say that over the last couple of years, we have two programs that I can highlight that have met that need. One was a research grant to Dr. Stephanie Cherqui at University of California in San Diego on bone marrow transplant for MPS IIIC. And the other is to Dr. Patty Dixon. You can raise your hand, Patty. I see you just walked in. We gave a grant to Patty to try and develop a gene therapy for ML2-3. And that's based on some really exciting science that has developed just in the last couple of years. So these used to be two of our most difficult diseases to think about treating, and we now have a rational path forward. To echo what Barbara Burton said the other day, I too can see a period when we have really gotten a fix for almost all of our disorders. It may be a decade or 2 decades before that hope is realized, but I can see the science out there that will lead to that. And these are the kinds of approaches that are going to get us there. So stick with us, keep hoping, and we will get there. Further examples addressing unmet need involve a couple of initiatives at the Society. There were a couple of areas that I perceived that really needed resources. They may not have been sexy or innovative science, but they had to be done, and they needed a lot of money, more money than we raise in our regular grants. So I pitched this idea to the board. They liked it. And last spring, we initiated what we're calling our challenge grants. These are grants for big projects, syndrome specific, that will address a serious unmet need and drive clinical progress for a syndrome. We had 3 applications. The Scientific Advisory Board approved 2, and the board has approved those 2 grants, and we are working with those institutions and investigators to finalize contracts. And we hope very soon in January to announce those and to kick off the fundraising campaigns that will help get those programs forward and deliver treatments. Other areas that are involved in research over the last year that I think are very notable, and you'll hear a little bit about this later from Dr. Linda Polgren. And that involves addressing unmet need for many of our neuropathic diseases where we can't really address the base root of the disease because we don't have the technology, but we can develop therapies or use repurposed drugs to address the needs of that community. And this is particularly true for the Sanfilippo community. And I'm highlighting this paper. It appeared in Nature Medicine. If you're not a science wonk, Nature Medicine is the New York Times of the science world. It's the very best. And this paper made a lot of big impact, as it should have. This is a drug called anakinra that is being used in a repurposed format to treat MPS III. And it's been successful enough that the investigators, including Julie Isengart and Linda Polgren, are going on to work towards a phase 3 trial. You'll hear more about it, but there is hope for some of the most difficult aspects of these diseases based on this kind of research coming forward. And I want to make a plug. Both Linda and Julie are past and incoming chairs of the Scientific Advisory Board. Another area meeting unmet need of treatment that has been reported over the last couple of years involves an approach to treating MPS I that is a gene therapy treatment of stem cells that involves ex vivo, outside of the body, in a petri dish, treatment of stem cells with the lentiviral vector. This initially was published in the New England Journal of Medicine. And this was really groundbreaking. It represents a significant potential improvement on regular hematopoietic stem cell transplant for MPS I. This is also a trial you may know of because it's being put forward by Orchard in a phase 3 approach. And the results are really impressive. And they have potential to be paradigm shifting in terms of their approach to treat other neuropathic MPS diseases. The first report that came out in that New England Journal of Medicine documented cognitive scores of children that were all in the normal range. These are children who were treated at 2 years of age. They did not have regular donor available because of poor matches. They were given this gene therapy, and this is their results 2 years post. Since then, the skeletal results, or the growth results, have also been published, and they show that growth 4 years out from treatment is all within the normal range. These individuals have supraphysiologic levels of iduronidase activity, well above normal levels, and that's 24/7. Getting that on board at 2 years of age has been significant. The phase 3 trial is mostly enrolling children who are treated much younger, so the potential benefit is even greater there. So look for these results to come forward in the future. I think they're going to be very exciting, and they're going to change the prospects for a lot of our diseases. This same approach is being expanded as well to other syndromes. So Orchard has a phase 1-2 trial in MPS IIIA, and we all hope in the community to see that move forward to a pivotal trial. Using this same approach of ex vivo gene therapy, researchers at the University of Manchester, Rob Wynn and Simon Jones, are now enrolling a phase 1-2 trial using the same approach except for Hunter boys. So these will be boys between 2 and 24 months of age, and they're going to get an ex vivo gene therapy hematopoietic stem cell transplant. Importantly, these are autologous transplants. They are your own stem cells. No risk of graft versus host, even though there is a chemoablation to treat the patient so the bone marrow will engraft. Engraftment has gone very quickly. In a similar approach using this same technique to treat MLD patients, over 80 patients have been thus treated, no fatalities, all engraft. It's been an incredibly exciting approach. So we're seeing this approach extended to MPS I, IIIA, and II. None are yet approved for FDA therapy, but we are hopeful that we will get there. Another incredibly exciting approach involves a company called InUsoft. Very recently, they just reported their results of their first treated patient. This was an adult. It's a very interesting approach. It's autologous, it's your own cells. They are not stem cells, so you don't need to be treated with a drug that will increase the stem cells in your blood. They're just taking your regular B lymphocytes, the ones that produce antibodies. They're taking them out of your blood. They are treating them in vitro with a gene therapy vector called a transposon-mediated gene therapy, and they get iduronidase into your B cells. B cells produce antibodies. Antibodies are proteins. B cells are great protein-producing factories. The first treated patient has been reported on. The levels were extremely good. And even more importantly, they found that the results showed GAG levels in the cerebrospinal fluid dropped. So this is a peripherally administered stem cell, or not stem cell, lymphocyte gene therapy, and yet we're getting enzyme into the central nervous system. So this offers a great deal of potential for attenuated patients, bone marrow transplant patients who may have the need of more enzyme. It could be a real game changer, not just for MPS I, but for other MPS disorders. We are waiting for the second patient to be treated. This is an FDA phase 1/2 trial. They're looking at safety, so they have to wait a certain amount of time before they can enroll the next one. But we are all very excited in the community around these results. So stay tuned to ImmuSoft. The Society has been doing a great deal of work in areas of rare disease initiatives. So I've been speaking at the American College of Medical Genetics. We were invited to present a short session on therapeutic innovation for MPS. This year, we will also be presenting there on the use of autologous lentiviral and CRISPR-mediated gene therapy in the MPS and LSD diseases. We also presented at Brains for Brains, which is a longstanding conference that has been reactivated since the conclusion of the pandemic. And this spring, we participated in the Every Life Science Workshop, and that is really around legislative issues and potentials to define ultra-rare disease at the legislative level. So currently, rare disease is defined legislatively as a condition in the United States with 200,000 or less patients. None come close to that level. And we have very specific concerns for our diseases that involve very small populations and many of the other complications that go with that. And so we have initiated with others a potential to look into an ultra-rare legislative initiative that would define ultra-rare as a disease with 2,000 or fewer patients. So stay tuned on that. Newborn screening is already changing the profile of what MPS I and MPS II look like. And we've been very active both at the state level, for example, at Virginia, with stakeholders, REGENXBIO, speaking at children's hospitals. I was speaking at Phoenix Hospital, Phoenix Children's this September, as well as at symposiums with the Association of Public Health Labs, both their national symposium and their new condition symposium. The Society has also been very active with colleagues around areas of FDA regulation reform. Just taking in the map, this has been shown many times already, but if you've missed those sessions, for MPS I, we are now at 45 states and territories and 86% of the birth cohort in this country. So making great progress. And we hope by 2026, plus or minus Puerto Rico will be at 100%. MPS II, we are just 2 years and 4 months out from approval by the Secretary of Health and Human Services, and we are already nearly 40% of the birth cohort in the United States. All I can say is God bless West Virginia for starting to screen for MPS IVA. They are the only state in the United States screening for that, and we're hopeful to see that initiative expanded. So as I said in my introduction, one of the things that inspires me about this group is the way we work together. And in the fall of 2022, Emil Kakkis and Karen O'Neill and I started engaging in conversations about what we could do to galvanize the LSD community and the MPS community to move the needle for FDA. Later that spring at World, it was clear to us that there were some real dangers presenting themselves for certain programs in the San Filippo space. And this led to the following letter, which was co-authored by the International MPS Network, the MPS Society, and Cure San Filippo. We garnered over 4,000 signatures for this letter that we sent to the FDA. And one of the things that we were trying to get them to initiate was an improved approach to expanded or accelerated approval to help drive approval for these rare drugs. I can't say that this letter caused things to start moving, but it was certainly part of the effort, and it helped galvanize the community, I think, in our mutual sense of need and effort. This led to an incredible symposium that was held this February that has really been a seismic shift in the way we think about regulatory approval for rare disease drugs. The Reagan-Udall Foundation exists independent of the FDA and has been set up by Congress to solve problems that just can't be dealt with within the FDA. Working with stakeholders, they initiated a workshop on examining whether CSF heparan sulfate levels could be used to put forward accelerated approval for some of our neuropathic conditions. And this was a huge success. We had over 12 attendees. 10% of those were from the federal government. So probably over 120 individuals from the FDA listening in. And the results have been incredibly successful. And as you can see from this picture, this was a combined effort. And I see many of the faces in the audience that were part of this. Mark Dant, I know you're here. Could you raise your hand? Joe Munzer, Terry Klein, Heather Lang, myself. This was a group effort, and it was incredibly important to lend. And Glenn is here. I know his wife is up on this photo. So it was really a tremendous group effort, and it had a huge impact. It resulted in this publication, and you can see in the author lists, we had Addie Dixon, Joe Munzer, myself, formerly an academic, industry from Allevix, from REGENXBIO, from Denali, from Orchard, advocates, the MPS Society, the Ryan Foundation, Cure San Filippo, coming together and driving home a consensus message had huge impacts. How do we measure those impacts? It was very clear. Within months, REGENXBIO announced that they had a successful meeting with the FDA that supported accelerated approval using heparan sulfate in the CSF for their gene therapy for MPS II. And the news just kept coming in. In September, Denali announced their MPS II program also was given the green light to use accelerated approval as an approach towards clinical marketing. I'm extremely excited, and Heather, forgive me if I'm stealing your thunder, to announce that yesterday, Ultragenyx said that they delivered their final biological licensing application to the FDA for the gene therapy that was initiated with Abeona for MPS IIIA. This means by this time next year, we have the very real possibility of having an approval for gene therapy for San Filippo. That for the community, that gives me chills. And especially, I think, for those of us who've been working in the San Filippo area. So on that high note, I'm going to end early, hopefully pad the schedule a little bit. And I don't know that I have the opportunity to take questions, but I'm going to hand this over to Joe, who I think is next in our lineup. Thank you very much for your attention.